Go ahead and call the order. Regular meeting for the Seneca Health Care District Board. In the room, we have Ken, Sherry, Rich, and myself. Shelley is joining virtually. She won't be able to vote, but she'll still participate. So if you could please rise for the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. That brings us to item number 2, additions, modifications, or deletions from the agenda and non-meeting minutes. Okay. And that brings us to item number 3, approval of the agenda. Do I have a motion to approve the agenda? Thank you. Do I have a second? Okay.
You win.
Thank you. All in favor, Rich?
Aye.
Tim?
Aye.
Sherry? And I will vote aye. That moves us to our public comment period. We didn't receive any public comments or questions or anything in advance. Anything anyone wants to share, either in the room or online? Okay, hearing none, let's move on. Item number 5, request for approval of the August 28, 2025 regular board meeting minutes.
There was one area, Shelley was not present. And in one of the areas that said that she had voted aye on something.
Okay,
And I don't remember now which one was, but I can look.
okay. Yeah, if you don't mind.
Well, you did correct that, yeah.
So with that, is there any other comments or edits for the minutes?
You approval with that, correct?
Thank you. That a second?
Sure.
Thank you. All in favor, Sherry? Aye. Ken?
Aye.
Rich?
Aye.
And I will vote aye. Thank you for catching that. Okay, that brings us to item number 5, SHD staff and, I'm sorry, item number 6, SHD staff and SHF reports. And Sean, you're up.
Sure. So let me jump in, by saying that, we just left our strategic planning committee meeting. I think we're gonna be on good footing and to be able to bring to the board, or at least the board members in the community are gonna be able to bring to the board some decision trees that are gonna be necessary for your determination on how you're going to direct the executive staff over the next few years, the priorities. I think that Brady presented a very good matrix that we're gonna be filling in. It has a lot to do with everything from program development and revenue development, cost savings to strategic planning around the campus decision making. So I want the board to know that that kind of officially kicked off today. You'll start seeing some stuff coming to you. And it's really to help us, it's to get the board to digest what's on the strategic vision for the next 5 years and direct the executive staff to follow through certain things. It's kind of a guiding board for us. And I appreciate Brady's work on that. You'll start to see that. Big things we're working obviously on is program development. And we talked about this a number of times in the board and a number of times in the executive meetings, is to determine the determination of program development prior to the opening of the new facility. It has so much more capability than what we have now. So we're not waiting until the doors open to start developing this. So as it relates to specialty care, utilization of the OR, and those types of things, I just want the board to know that it's in a constant it's in a constant communication cycle now about the things that we need to do prior to the opening of the doors. If you have any questions about that, you can reach out individually, but I can tell you that it's an agenda item that never goes away now. As we start to approach what I would say almost final approach, we're kind of coming in and dialing in as that thing starts to develop. Those are the kinds of discussions we're having. In addition to that, it's our transitional strategy. It's a lot to go from there to there, running kind of for about 2-month period. You're almost running 2 hospitals for a period of time. And then what the transitional strategy is, we will be issuing, and I don't know if Dawn is on, but we will be issuing an RFQ for a transitional strategy team. And this is very common, that you have a consultant that is used to doing this, everything from moving a box and moving that chair from there to there, making sure it goes in the right place, to how's the sequence of events going to happen as we start to transition into the new facility. That RFQ will be going out. The USDA is aware of it. It'll be going out. But that's the other part of sort of our planning in the winter now, as we start to approach what is becoming a very real building. and a very real,
What's your initial time frame for this vendor coming in? You don't know?
January 1. I mean, we're hopefully to get a vendor, a consultant on board first year.
Yeah, so what we'll get, contract process done, and then probably have a lot of discussions with them. Judy and I are already,
Yes.
doing our TSC meetings to get everybody kind of thinking that way in their new space. And then come summertime, it's game time, because then there'll be enough structure in there that we can start talking and walking and all of that. Then Judy probably, October will do, the start of staff and stock, which they are heavily involved in. Because it all leads up to licensure, and we have to have that all sequenced properly.
Suddenly it's coming very real.
Yeah.
Very real. Looking through the, you don't have to look through a telescope anymore to see it. It's right, it's visible by the naked eye. And I can tell you that starting January, it is going to be a very, very busy year. It's gonna just begun, it's just gonna start happening. And having a company that's coming in here to guide that process, they have sort of a framework for it. You know, what's on first, who's on second, that's really important. And so we'll have that. So at least we'll have somebody who's keeping an eye on the sequence of things. The staff will be extremely busy. So busy summer, busy transition. To get to our fall, and be prepared.
Are we thinking we're gonna have to increase our staffing levels for a period while we're transitioning?
I don't want to say increase our staffing levels. I say that we may in the next budget cycle be incurring some overtime that we have to consider for. We will be obviously,
Many of our managers are still doing shift
they're
work.
working.
We probably have to take them out of that at the very.
So I suspect the next year's budget is going to see a flux in either locum use for a period of time or overtime, premium pay. We obviously want to offer it to our staff first. I think that's just a good idea, but I think it'll be part of the 26-27 budget cycle. Yeah, and then of course, there's the things that'll be coming to the board from a transitional perspective, that what the staffing ratio is gonna look like, what is the staffing need gonna look like for the new facility, given the extra beds in the skilled nursing, the larger kitchen, the bigger ER, the larger 50,000 square feet instead of 16 for our environmental. So these things are gonna start coming your way after the first year pretty quickly. Just want the board to be aware that you are very much part of that transition plan.
Sean. I have a question. This is Shelley. So what is our current locum use in the ER? Has it gone up?
Down.
Okay,
We are, I mean, we have some, locums that we've used for years now, so we have probably anywhere from 2 to 6 shifts that we cover with those group of physicians for probably the last couple of months. And as we move forward, that gets less and less.
okay.
You're talking about physician locums?
Yeah, I knew that's where we were moving for more stability, is to
Yeah.
decrease our locum utilization, but I was just wondering where
We
we
are.
were.
Yeah, we are definitely seeing a great deal of improvement. We're really starting to get a kind of a stabilized group in there that are committed to us. And that because of that, we're able to improve quality, and expectations around documentation and those types of things. The whole idea is to get that stabilized group, completely get away from locums. You may have to have a couple lingering out there that you like, that are good for vacations or unexpected
Right.
things, but getting better for sure.
Good, great, thank you.
Okay. So, board be aware that the first year is gonna just be it's gonna be a big year. 26 is gonna be a huge year for Seneca. And a lot of things coming your way. Good for you. Yay.
I'm anticipating special meetings.
I imagine there will be some special meetings popping up. Yeah, look at Steve over there, yeah. I don't know, you're just flapping your wings, okay.
Approved.
What's that?
Award 13 approved.
Yay, okay, good, that's great. Good, before the government shut down on Wednesday?
Yes, we can celebrate that.
So let's bring that up. Okay. It looks as though we're going to a government shutdown, as of Wednesday. It doesn't, we don't understand the impact yet, although we've been forewarned by the USDA mostly. I'm a little worried about any other federal things that have to go on, pertaining to some of the structure out here. I think we're in a good place. We're mostly with the state now, which is good, but I'm not sure how funding is going to affect any of that. I don't think it's going to affect us, but the USDA has forewarned us that if they get furloughed, then our pay applications and the things that we're trying to get done to pay our contractor, and quite frankly, our soft costs to our contractors, to our consultants, we're pushing it through, we're trying to get it through. I don't know if we'll make it by Wednesday, but that could be delayed, and that's a concern of ours. Last shutdown, it was a month. I don't know, and even the USDA is not sure if they're gonna be furloughed or not, but I want the board to be aware that that's a huge issue for us. And we're monitoring it.
Protracted,
What's that?
could become a protracted thing.
Yeah, it just falls down, just keeps going downhill, just keeps moving and moving and moving. No government updates as it relates to legislation. Big legislation, the stuff that we knew would be signed or is signed. I think it's too egregious for us. A lot of stuff that was really egregious got held up. It's in a 2-year term, so it got suspended, usually in appropriations because there's a budget problem in the state of California. And I think the state of California is still trying to figure out what they're going to do. And still trying to look at some of the federal money that may or may not come in. So I think they're being kind of cautious about their own budgets. So they suspended a lot of stuff in appropriations because they simply don't know. That's good for us, gives us a little bit of a reprieve, but I got a feeling it's gonna come back fast and furious next session, next go around. Some stuff is really egregious to us. We're still trying to write legislation to soften the whole metal detector issue there's some follow-up bills being introduced into the state through some of our local representatives to soften the blow and the requirements for stuff like that. I can tell you there is notification that critical access hospitals and rural hospitals, I think the message got out there that they're under duress, and the modeling shows even more duress. So I think that the state legislature is very apprehensive to lay more stuff on right now. So that's why I think they suspended, but it's not going away. Believe me, it's not going away. They're kicking the can down the road. They do, the federal government does come back into session, expecting reconciliation bills. I know Steve's gonna be watching any reconciliation around HR 1. I think we're going to see a lot of reconciliation bills coming in to try to soften the blow of HR 1, or at least create some clarification around HR 1. But we'll be watching the activity in Washington very closely over the next probably 2 quarters as things start to move in. Okay, that's on the government side. Any questions so far? All right. Community outreach. We're really this year going to be, well, we have been, but really going to be pushing on community outreach. We had a really successful town hall, although not well attended. I guess, Chelsea, there was a lot online. We were able to present as the primary presenter and really gave them a really good view of what's going on here and some timelines. I thought it was really well received. We received a little bit of feedback, mostly positive feedback, some negative feedback because I like to crack jokes and some of it lands and some of it doesn't. Such as stand-up comedy. Sometimes you're gonna hit it, sometimes you're not.
Tweak our curiosity.
There's some, I'd like to add flavor and sometimes the flavor falls flat. I don't get it. I thought it was funny.
No more blue heron jokes.
We're done. For those who haven't heard, so the town hall actually went very well. I suspect that we'll be carrying through that through the winter. As there'll be updates internally to the building, the TI improvements. The community, I want to make the community aware that as of this fall, they're not going to see a lot of changes to the facade. But we really need to be out there and really need to share what's happening inside. Our videos, our weekly updated videos are being followed. They're being very well followed. I mean, how many views and followers? It's a lot.
It depends, but yeah, it's usually over 1,000.
Local. Then it gets shared.
And then 200 views for your town hall.
So that's great. I think the community, today we had our, See Your Money at Work Day. Again, not attended like I would expect you to have an attendance, but as we know from our community that they tend not to, they won't come to something unless something's going wrong. I can tell you that the folks that were there were, when they got in the back and looked at it, were like, wow, it was
They had a lot of questions for
a
sure.
lot of questions, good questions.
Yeah.
I think it's going to spread exponentially. I think they're gonna tell 20 people. So the next event that we have, hopefully, we get more and more activity. The whole purpose is to build along with our transition plan, as along with our program development plan, is to build into that energy that we're gonna carry through next year into the certificate of occupancy and eventual opening. Constant build.
That I saw here today, we're not the same people as at our
Right.
prior events.
Correct.
And I thought that was really encouraging,
Yeah.
because different people
Yeah.
are coming and seeing what's
New
going on.
bodies.
Yeah.
So, in similar fashion to passing bond originally, we were building a groundswell of activity. It's gonna be a lot of marketing, a lot of outreach, program development, which is internal, strategic planning, which is internal, and then sharing it with the community. So that's, at least my goal is to build a huge amount of energy into this next year. Okay? I do want to invite you, we got an invite. I would love to see a couple of our board members, at the Plymouth District Hospital's opening of their skilled nursing. It's invitation. We can forward you the invitation if you're interested. You have to get a ticket. It's October 7th between 4 and 7 in the evening. This has been, and I wanna hand PDH a lot of props. This has been a real bugaboo for them. It was supposed to open in April. And I know that they've been working to get it open. I can tell you, it is competition. It's gonna be competition for staff, CNAs, but it's okay. We're not afraid of competition, but I do want to show a lot of support for PDH. As it has been a really challenging project for them. So if you'd like to go, get a hold of maybe Chelsea or Judy or myself, and I'll send off the
Or the times on that again.
4 to 7 in the evening. They're asking for a ticket. You go on, they have a ticket, to get a ticket. Yeah, I think they're gonna have food there. They wanna know how much. But, we'll send you the link if you'd like to go. I would love to see Seneca representing very well, in support of their effort.
They have a class that evening.
Then you're not going, unless you can tell your students that I'll do what I want. That's it for me. I'm sure there's a million other things that are going on that are constant, but I'd like to just open it up to the board for any questions for myself or anybody else from the executive team around these subjects.
Questions, board members? Shelley, do you have any questions? She's still on.
No, I do not. Thank you. Very good. Very impressive, Sean. I had the personal tour last week of the hospital build to date. Very impressive. It's really exciting to see.
It is exciting, and thank you for referencing me, but I can tell you what, that this is a huge team effort. I
Yeah.
mean, thousands and thousands of staff hours and the contractor. So thank you. Thank you, Sean.
Sure.
Thank you, Sean. All right, Judy, up for your report?
Yeah, so, sorry, I was kind of considered just getting report, so this is my report. It's a very, very busy place. I just want to remind everyone of that. It may be tiny, but it is mighty busy, so. Next week, we're having our active shooter drill here in Chester, so it will happen at one of the area schools that Seneca's going to play a big role in it, and we're keeping our objectives pretty limited of what we're trying to accomplish in testing our own system, such as, have we used our unidentified registration system within Cerner? Can we track a patient from the time they hit our campus to the time of family reunification, et cetera? So those are the main things. It's actually more of a tracking thing that we're trying to do. So it's not that we are expecting all of our nurses to come in, or that we're going to see how many, active bleeding patients we could actually operate on, or what have you. This is really just the core things that we have not tested in our current EHR, et cetera, that we're working on here.
And I want to add to thank you for focusing on that. I can tell you the things that fall apart in a mass casualty is the administrative overhead. It's the site, it's tracking blood bank. I mean, all these things just,
Yeah.
you're so focused on the trauma that we forget all of these things. So I love the focus. Family control.
Difficult things to be dealt with in real disasters at Enloe, was media control.
Mhm.
And media sneaking into the hospital, trying to get to the children and things like that. This was a little bit more emotionally charged. Whenever you have a drill that involves children, it automatically increases the stress level like so. That should be interesting.
Wednesday, is that Wednesday?
Mhm.
I'm confused as to what initiated this. Was this a state requirement, just something locally?
This is a
County.
county. Yeah, so
countywide?
counties are required to do a certain number of drills annually. And so typically they will test different parts of the county, but with the same types of drills. So whether it's a biohazard drill or an active shooter drill or
Dirty
what
bomb.
have you.
Yeah.
Our last drill was actually a biohazard drill where our chem packs, our medications are stored in an area of the county that we are not privy to know. There's only a couple people that actually have that knowledge, so that's not broken into or et cetera. So that was a very interesting drill last time. We learned a lot. I think we're gonna be learning a lot with this one as well.
For sure. So on Wednesday, if you hear lots of sirens, it's okay. And there will be, there may be helicopters flying over top. Could be anything. We don't know.
But yeah, you
So-
probably will
so
hear
Judy?
some silence and helicopter noise. Yes,
Go
ma'am.
ahead, Sean.
I have a question, not to get too much into the minutia of that, but are we going to, is county mental health going to be integrated into this drill?
Great question, because the county is doing the overall planning of this, so, we are only involved in that. Seneca provided, stop the bleed kits to the schools, and then the county was taking over on the training of how to, initiate the stop the bleed, whether it's with a tourniquet or a shirt or what have you. Who all the players are, I'm not even aware. We just know we're a player because we are in Austria.
You would think so, for counseling of things
Yeah,
like that. You
yeah.
would think so. I would hope that the county would deploy mental health
Yes,
professionals to something like this. But once again, we're all sort of guessing as much as you are.
right.
Don, can I help out with that answer?
Please, Linda.
Sure.
So, we spoke about this topic, at length yesterday, regarding the stressors of this type of drill on the, players and the children. They tell me I, being Seneca, would have normally looked to bring in, if behavioral health or mental health wasn't available, clergy or the sudden death hospice volunteers to assist us with the emotional state that occurs during these sorts of drills. The county assured me that the players have been well vetted, that they will check them through again, their emotional status prior to the drill, that the players will be told that if any time they start to feel overwhelmed, they may just up and stop playing in the event, and there will be a critical debrief and support continuing for those folks after the drill.
Well, that's good to know. I didn't realize that they were going to do that in case there was, it got too real, but I'm talking about in the drill itself. That they're probably.
I'm not sure what'll happen
As
at
part of the
the
drill.
actual time of the drill, but they have planned this out to provide support.
Okay,
Thank you, Linda.
Thank you for that. Belinda is definitely been very active, on St. Louis. We're gearing up for flu season. We have our community food clinic scheduled for October 21st. So if you have any community members wondering, that's when it will be in Chester. So we will provide the nursing staff, and our auxiliary will be on hand, as well as some public health nurses. And then, we will be offering our own employees flu shots during the month of October, and I believe, and Katie, if you can hear me, I believe it's November first, if, those that have, decided not to get their flu shot and their, patient facing, they will have to wear surgical masks until they get their flu season, which is usually April 30th, but that's called by our public health officer. Katie, did you want to add anything to that?
No, I think you're correct on that. It'll start October 1st. We'll offer the flu vaccines through November 1st, and then those who choose not to wear or not to get the flu vaccine will start wearing a mask November 1st. They can change their mind throughout. They could always get the flu vaccine later if they wanted, but we do need to have a declination on file. And then the county will decide when the flu season is over, but normally it's either mid-March to, or sorry, mid-April to the end of April.
Thank you, Katie.
Are you seeing anything right now starting to emerge in terms of prevalence of the flu?
Not quite yet. No, we're still seeing COVID.
And are they still offering, going to offer the larger dose for everyone?
Yes,
First time.
in the, drive-through. Katie, do you know if we're doing, the high dose?
We do have high
Yes.
dose available, yes.
Fantastic.
That's fantastic.
Not at the flu clinic though. The flu clinic will just be the regular dose.
I think only primary care offices are doing the high dose.
Yes.
Like that's the pharmacy?
Oh, or the pharmacy, but not in the drive-through flu clinics. We don't consider that. All right, I just wanted to, do a shout out for how impressed I have been with our hospital staff recently. We've had some very critical cases coming through our ER, and I really see that some of the drills that we have run, where we always do a debriefing and we're learning from just practicing things, because that's the way to do it. I'm actually seeing those things come to fruition. You know, we learned from the drills. We were, late in getting the Lucas device placed on someone getting CPR. We had a patient come in and CPR the other day. One of the first things to happen was the Lucas device went on. So I've just been really impressed at the collaboration between the acute care staff and the ER staff. It's been really great. We've been really focused on doing formal debriefings immediately following. Once we get the patient in the helicopter and they're off and on their way, then we bring the whole crew back together and they have an opportunity to verbally say how they felt in that moment, or they don't have to speak if they don't feel comfortable. But the last one was ran by Dr. Nielsen, did a wonderful job. And I just really feel like we're elevating our level of care overall. And it's really great to see the staff working so wonderful together. Something that we've been working on from the minute I hit the door here. And it's really cool to watch. So our educator was there. She offered written debriefing forms for those that may need time to process. And so we're taking all of those debriefing forms too, and developing our education, our experiences such as that. Right?
That's great, Jackie.
Already mentioned, we are going to be putting on a CNA class the first week of January. It'll be a 12-week course. So if you know anyone in the community that wants to get into the medical field, this is their chance for a paid training. We're anticipating CPH to be on campus at any time for our annual survey of our long-term care unit. They usually come before snowfall. I am working on coordinating the celebration for Dr. Ware's retirement. It's tentatively scheduled for December 3rd, which is a Wednesday. That's typically the day that she doesn't have office hours. That worked for her, so more to come about that. And Sean and Brady have talked about our transition steering committee meetings. It's an internal process that will be augmented with our transitional team that we will be hiring. So We're gonna start those back up as a winter project, but those tend to start small and then grow and grow, so we make sure that we have all the players necessary for whatever department it is. Some of my departments that will be truly enormously impacted by the move to a new hospital will be our skilled nursing facility, as well as dietary, because they're really expanding not only the volume, but their duties overall. And so we had a really good chat this morning with Steve's team. We have a meeting that we have called LTC Connect, where we have finance and registration, all of us meeting regularly to just do a pulse check on how things are going in long-term care. And so we were talking about our strategy and how we're going to look at occupying those 26 beds. With between the staffing, the training, all of the things. And so, I think we're all on the same page as far as how that should look without getting too, far away from the current type of residential custodial care that we're used to providing versus getting too heavy into the skilled nursing side of things. So, we will have a strategy on how, quickly we'll be able to actually occupy all of those beds, moving forward once it's open.
Yeah, because our original, we'll have whoever is here at the time for our initial
Yeah,
core.
they'll be the easy ones, and then that, seeing how it is set up in actually like 2 pods with 13 potential residents per pod, what that staffing looks like, what that workflow looks like with some shared staff, some not shared staff. It's gonna be one of the more, the bigger transitions that we're going to make in the hospital.
And that because of its geography and because of where it's located in the facility, it's going to be its own service line. It's gonna be its own self-contained
There's no
department.
more yelling down the hall and there's a bunch of nurses sitting right there on acute
Yeah,
that can come over because they're on the other side of the hospital with a lot of departments separating. So it's gonna be a big culture change for us as well. So all things that we will be focused
Yeah.
on in our internal TSC meetings with the focus of our external transitional, as I understand it, is helping us get through all of the regulatory requirements for training, drills, staffing to get us through the regulatory bodies. Any questions? That's the end of my posted note.
Well, going on, Judy.
Thank you.
Oh, sorry, I do have one quick question. The county, their emergency committee meetings?
EMCC.
Yeah,
EMCC.
has.
Oh, yeah, that's 2 weeks.
Oh, okay. I didn't know if there had been one recently, if there was anything. that you
It's
had.
quarterly, the last one was in July, we're coming up in October.
Okay, so my timing was almost right. So next week.
Yeah, and we will be setting up another meeting with Chief Gray here soon for the EMCC subcommittee, just because we want to continue meeting at least quarterly to keep a pulse on how things are going with them in the basin, EMS response, et cetera.
And how
that
we're
we
doing
can
with
help
them
them.
too, yeah, perfect, yeah. All right, thanks, Judy. Any other questions for Judy? All right, thank you. So that moves us on to our HR report, Shanna. Oh, wait, I'm sorry, Brady. I just checked your name. Sorry, Brady.
I was the middle child, so thank you.
He wasn't gonna volunteer.
No, he wasn't.
So, couple shout outs, so the reports in here, big things, the VFC, we passed, so JJ's team, we passed, and that's the vaccines. We had, an audit, the other big thing, which is,
Is that through partnership or is that something?
no, that's its own entity, the vaccines itself, and then they audit everything, making sure that everything is accounted for and goes right, which is, kudos to all the clinical team to keeping everything straight. Partnership, we had our survey, in partnership and thanking, the team. Cause there's many people in there, and this is our second survey, and our last survey that we did last year, which was for 3 years prior to that, was our first time, and it was eye-opening when we did it. This time, I think we were better prepared, understood how they surveyed. And so we passed in both elements. There are certain things that we still have to improve. And so the team is taking those and will implement those going forward. The next survey for this group will be 2 years from now. So instead of every 1 year, now it's 2 years. And the thing we learned the last time, which was keeping JJ, Casey, everybody up at night, is if you do not pass the survey, you can't accept new partnership patients until you do the corrective actions. So we passed. Kudos, thank you for everybody involved.
If they give
Pizza
you
this
a,
Friday.
I'm sorry, if they give you a corrective action plan, how long do you have to implement that?
Each one of the elements, depending on what it was, it's a certain time frame. So some of them is 30 days, some of it's 10 days. It all depends on what the element
How important
was.
I think it is.
Yeah. So,
Brady, did you get any hints as to maybe new metrics they're gonna be focusing on? Next year?
it's not hints, but there was things that they brought up, which we thought were new. Like brighter, future, brighter future, there's certain quality elements that they're looking for, and so that's the work with Ethan's team and the clinical team to making sure we're capturing all of those elements. Cause what happens, remember, they're an extension of the state, or they have the contract, so if the state changes something, next thing you know, the partnership is telling us, okay, you have to monitor lead or whatever it may be from the state, so. But yes, it's always, we're always learning something as they come, which is good, it's moving us
Right.
forward.
Thank
Yep, and then Linda's team has been doing a tremendous job keeping everything up and running, and sometimes it's a feat. So kudos to Linda's team, and there's elements of what she's done. Ethan, when it comes to the IT, there's probably we've had some outages, there's the projects there, and maybe give a update on the radiology project and how that is going, start, stop, that kind of stuff.
Yeah, absolutely. So currently with our radiology providers, our first order of business was making sure that our services did not go down. We had a hard deadline for that of December 1st, which we met. We never have stopped because of the way that Cerner integrates with our PACS, and our PACS integrates with the radiology feed. We are unsuccessful with having certain fees drop. We have been troubleshooting that. We have been troubleshooting it for about 3 weeks now. A lot of delays have come from the Cerner side. There's a lot of very specific types of messaging that need to be passed back and forth. So every fine tweak that we have feedback from both sides to figure out, make sure that it's going through correctly. We do have the tunnels completely secure and built, so things are passing back and forth without any issues at this time. However, because the intricacies of the messaging, they're still seeing some fees not drop what they should. It is having significant impact to what we can and cannot bill right now. However, once that is secure, we should be able to push that out as a batch and resolve all of it at once. So things are progressing with it. There's a little bit of slowness from some of the vendors involved. We are in a much better place now than we were even last week. Progress is rapid.
Okay, thank you. Then the other thing is, one of the things, so we get into the quarterly reports from the metrics and the charts. One of the things we added in the partnership members, because now we're very familiar with it, is the inactive member. So it's total members, new members, retained members, but inactive means that for some reason they're not on the list. We don't necessarily know that. but we started quantifying it, so how many we're gaining, how many are we losing, so that kind of little more granular detail in that slide there. And then when it comes to the other analytics, this is just the quarterly reports of the word clouds, of the percentage here, so you can kind of see as things are growing, which cloud, you know, which words are larger. Our referrals, current state of the referrals in the pie chart of the types of referrals, this will dictate for us strategically talking about service lines. And then the zip code analysis, which we developed, the one area that, as I was reading this, it's like you go from 2024 to 2025. You do see, you know, the grand total. Now granted, this is January to August, the numbers are slightly lower, you know, from the period of the past to the period of the forward. And then I would look at, you know, the primary area, the service area, and it's not necessarily one area or the other, it's a little bit in all of them. So do we know the why? No, but this is just the migration of patients. So that's something that as we get to the next quarterly report, is that still doing that or not?
Do we know if these patients have appointments or they come in the walk-in clinic?
We could get that granular. This is just, what, you know, they were captured by us, they were seeing, not necessarily walk in or where, but we could do a primary care versus walk-in kind of analytic on there, so you can see that. We could spin it down a little deeper.
Yeah, okay. Do you suspect that with passing the partnership thing now that we'll be adding additional patients to the, what, did they mention anything about now that we've passed adding additional patients to our cohort?
Yeah, they're always adding,
So you'll see it was flat, so.
yeah, they're always adding, you know, so many new members per month. The question is the inactive members. Now, with Baba and all of that stuff, because it's the roles, which that somewhat captures, so, and the neighboring community doesn't have the provider again, so we may see a little uptick in that, but we may see people drop off the Medi-Cal roles, so that's just some. Yeah.
Are we seeing retro terms? Because I know that was an issue where I used to work. You know, you get the monthly membership and you would have some that looked to be inactive, but they were actually retro termed like several months later.
Oh. Yeah, no, we haven't looked at it from that perspective,
Okay.
but I can dig into that.
Yeah.
And then the last page, so the last page, which I'll leave that for Shanna on the recruiting update. But MRI, all the 5 hospitals, it's finally at its last place, which is CDPH, and they are starting to get a little bit of emails from them, so I'm hoping, and Linda, if you have an update, before, you know, Monday, I think it was, please jump in, but I think hopefully by next week, we should get, you know, communication back from CDPH for all the facilities that we can start, you know, moving forward on the MRI
Once
side.
we get approval, how soon can we start?
They're ready.
They're ready. We've already done our dry run. Yeah, Ethan's done, you know, the integration, Linda's done their part, the fire marshal. It's just the final, you know.
So they could get going the next day?
Probably, I mean,
The rig is in our county.
yeah, so,
I think there was a letter that went out that said, hey, these communities have now been without MRI for a year. Can we please move the
Yeah.
ball? It's really affecting care, so.
So, and with that, is there any questions?
Questions for Brady?
Well, I wondered if you could jump back in, I was curious about this outage and notable occurrences here, and apparently there was a fairly significant outage.
Yeah, Linda, do you wanna speak to that? Is Linda there?
Can't see the list.
Did you leave?
She was, but I don't know if she's still there.
Yeah, so, gotta see which outage it was, that's how many outages several we had.
Yeah.
So, we've had over this last period of time, we've had a power outage, and that power outage affected all of us. It was somewhere in the transfer line, and I was talking to PG&E representative, and he was explaining how those transfer lines are set with sensors, so if something hits it, squirrel jumps on it, whatever it may be, it de-energizes those lines, so one of the outages was that we've had, kind of an interesting outage with, phones and, Cerner stayed up, but the phones line were out, it was, a little odd. So we've had some, multiple types of outages from communication or electricity in this last month. And the ironic thing is, like, when the power went out, it was a bluebird day. It was a beautiful day, so we're not even into the storms yet, but, so yeah.
So, and in some cases, the generator was required or not required?
Always, yeah, always, so.
Was it effective?
Oh, yeah, no,
Captain?
the beauty of, our campus is we have generators everywhere, and this is Linda's team making sure that we're, always ready. And so as soon as the power goes out, it doesn't affect our operations,
To a certain degree.
to a certain degree.
CT.
Our CT, and you'll see in that, is that the CT, because it was put on after the facility with the size of the generator, it is not on generator, so we go on resource alert, meaning that if any patient is required a CT, they bypass us, so that's a function that we go in with, EMS and, all of that. So we did do at that time frame, we go into that mode, but the other operations still go up and running, and even the clinic that right here, this generator keeps this thing going, which from all the organizations that have been around, having the generators on almost every building is pretty cool from an operations guy, because it's not like you have to cancel patients and all of that stuff, which a lot of facilities have to, so.
I will tell you, new facility has been sized with the appropriate amount of generators, and the e-power is much more diversified, so we have e-power everywhere. And that was purposeful because we don't have enough e-power, emergency power over here. So we've dropped in probably an overabundance of e-power over there. Cause we want everything to work. I mean, the OR should function.
Yeah.
So, yeah.
Well, given our climate in the wintertime, it's a very good idea.
Yeah.
Thank you.
Yep, you're on.
Oh, one question, Brady. Has the road construction impacted the clinic as far as people being late over there?
Yes,
For sure.
and so we've
To what
had,
degree?
well, it's to the degree that in every message of scheduling appointment, we remind the patients about the road construction and give yourself, 30 minutes to get here, the office asks, where are you located? Remember, there's road construction, make sure, because our providers, and it's up to the providers, but, we give grace about 15 minutes, but once it gets over, 30 minutes, then we try to, get them in if there's openings, or we try to get them into the walk-in, but it gets trickier if they're, stacked on the schedule. So we've had to implement the process, because prior to that, we had people showing up 30, 45 minutes, and those providers are now moved on to the other patients that are here, so it's impacted quite a bit.
So I also think it's a lot of people that would normally schedule an appointment, don't want to deal with the hassle. So I think it might have, and I can't prove it anecdotally, I think it might be correlated to some of our decrease in the number of visits that we're seeing. They just don't want to come in. I did experience, I'll give props to your team, experience a gentleman came in today from Susanville and missed his appointment by almost 30 minutes because he didn't expect the amount of road construction. And the team up there was working really hard to get him in. Cause once again, physician moved on. But I think they did.
Yeah.
And it really throws a wrench in things to answer your question.
Yeah, so I'm hoping as they are finishing the signs that they will be done with the road construction for this season.
Please.
This is another earthquake.
Yeah.
Until there's another earthquake.
By then it'll be ice and snow.
Yeah.
Yeah, but people up here are tough. They don't deal with that.
That part's true.
They don't care.
Any other questions for Brady?
No, but I had a kind of an incident or a suggestion as a result of it. In the hospital intake, the two ladies that are in there.
Yeah.
One of them, this is very, I almost hate to mention it, but one of them, the desk is set up so that the computer, the monitors are off to the side. And the patient sitting in the chair has eye contact
Yeah.
with the person. The other one isn't.
Okay.
They're both really big monitors and they're right there blocking that person in the chair from being able to see the person they're talking to face.
Got it. Okay.
And I noticed twice that people were there that seemed to be really having a hard time understanding. And I think it would have gone a long way if they could have seen the person's gesture and face and the whole thing. So if there's some way to rearrange that second intake,
Okay.
so it's a little more customer friendly.
Yeah.
I think it would make a really big difference.
Yeah, coming from a height impaired guy, I fully understand that.
Yeah. Well, I've not normally had that problem, but.
Thank you.
Thanks for that, Sherry.
Mhm.
Okay, then I think that's all for you, Brady.
Yep.
Okay, sorry, I tried to skip you earlier. All right, now we go to Shannon.
Okay, so our medical staff coordinator is set to start October 20th. Tentatively, he's looking at the housing, we still have it all figured out in the next week. Joanne has been very flexible with us and being able to train him in person a little bit longer than she wanted to be here. But that is, that she's gonna do that for us. Physical therapist recruitment, I am trying to get some more contracts in place. We have 2 perm placement recruiters looking for us with a potential agreement we're working on. We're now pursuing a long-term contract, so travelers to come in. I have 5 companies currently looking for us. And then today I was able to post the job posting on the California physical therapy job board. So hopefully those efforts will start bringing some in. Judy mentioned the CNA program that will start in January. I am working with Butte College to get funding to help support the program, so that's in the works. Attended a job fair, it was more high school students, it's still good to have exposure out there. We are scheduled to do our negotiations in October, so that's coming up. And then physician recruitment, we have extended an offer to Dr. Gray. And Brady is actively working with him, about the terms of the agreement, so that's moving forward. But until we are finalized, we're gonna move forward with recruitment for a position, so I have my statistics there. Still haven't gotten any applicants from these platforms, but we do have an open rate, 50% or higher for what's being sent out.
The job view jumped too. Wow.
So I tried to focus a little bit broader. Last month I was focusing a little smaller California states closer to us, so I brought in my search. Let's see here. No additions this month, a little bit slow on that side. We do have our medical staff coordinator and a kitchen helper, and the onboarding process. lose an LVN per diem, and, we had a couple people leave us. And,
Any questions for Shannon?
yes,
Can I add a little on?
yeah,
Okay, so, Shannon talked about the primary care, we had in the specialty care, we had our, second, podiatrist that's partnership with PDH come last Friday, and, you know, we do the tour here and then did the tour out there, and amazed of what we're actually doing here, so, I'm feeling good about that service. We have, on the cardiology side, we have, you know, Judy and I know quite a few of the cardiologists down in the valley. And we're getting some good response, from that aspect of it. ER, we tend to get, more and more docs that wanna start either permanently doing, an ER, you know, like full-time shifts or, 2 shifts. So, I mean, we're on a good pathway of, not using locums, at all, probably starting next year. And then we have, another provider that is hospitalist and skilled from a recruiting standpoint that, you know, we're kind of in communication with. So we have a lot of activity. And I'm hearing more and more of this activity is because of that, you know, what you guys are doing and what's going on up there. So it is helping in the conversation.
Brady.
And we also have students from the Feather River College, LVN students that are in our hospital, and the feedback from their instructor is they're enjoying this a lot more than the other facilities that they've been in, and the other facilities are jealous.
Or what? So,
I think Shelley might have had a question. Shelley,
Yeah,
did you have a
Shelley.
question?
Yeah. Brady, you mentioned Dr. Greg. He's the physician you interviewed for, I assume, replacement of Dr. Ware. Is he interested in full-time or part-time or?
Full-time, yep,
Oh.
it's a full-time position.
Judge,
Well,
that's his opinion?
this might be,
Or
it might be,
impossible?
yeah.
Well, the conversation is, you know, we're in the negotiation phase, so the conversation, he did bring up the opportunity to do ER shifts. So we'll probably add that to it, but mainly is a replacement in the primary care, so we keep our, you know, the 5 FTE number there.
Yeah, no, I was more curious, I think, whether he'd be following his patients if they were in the hospital.
Yeah, from a hospitalist standpoint, and he, and all the recruits, that we've been talking to, because that's a model we're looking at, and kind of really digging into it in this winter is actually being a hospitalist, you know, rounding on their patients, all of that stuff, the skilled facility, that part too. But yeah, that's in the normal, dialogue, but.
Do you have a question, Rich?
No,
Oh. All right, thank you. Anything else?
No, that's all I got.
All right, perfect. Chelsea, looks like you're up for the marketing PR. Very soon. So, how is my recommendation?
Great. Okay, so, been busy, so we're doing a combination. So this week was a busy week. We had the town hall, then we had the staffing signing, and then today we had the See Your Money at Work event. All of those went well, like Sean said. So just a brief overview, so we're going into our winter season. So we cut back on some of the things like the geofencing we cut back in the winter. We focus more in on the winter on like primary care and on our local residents and trying to target them a little bit more. So what's interesting is our ads that have been like going out locally lately have been all about, are you established with a provider? Do you have a provider? And so that's what we were working on now. Our next ads are
yearly physicals, and it's showing like the importance of yearly physicals and all those things. So, working with Brady this last year, when we looked at stats of like when things start to drop or when things start to go down, that's when so before that happens is when we're trying to push things like yearly physicals or things like that to remind people, get in, come back, so that ideally those areas that we typically see over the year where we've had a drop in patients, we can try and bump those up because we're reminding people like, oh, this is a good time to do that. So that is, one of the things that we're doing. We had several press releases go out. We had some scheduled to go out as well. Any questions on any of the press releases or anything like that? Okay. Other than that, there's lots of website updates going on. We're doing some stuff. So Charlene has some website updates we're working on for her department with HCI. We're also doing a lot of stuff with Sarah Lynn and billing with, the website as well. So, with financial assistance, charity care, all of that stuff, there's some different requirements and some partnership page updates for partnerships. So we've got some of those going on right now. And then, just our typical monthly newsletter, for the country club, we are still advertising in there, but they switched from their monthly newsletter to now goes to bi-monthly. So the next one that'll come out will be November, December, and then it does a January, February, all of that. Radio marketing, we do have, some additional live spots scheduled, for October and November. And then employee appreciation, so, we did the taco dinner, which was the bean signing, and then we're gonna be starting Christmas party planning. We will let all the board members know about that. We, encourage people to come, and, we still have the packet pending for MRI, so as soon as Brady gives us the go-ahead, we'll release that. We get a lot of questions about that, so the community is wondering, what's happening there. We have a postcard ready to go out for provider recruitment. We also have, starting next week, is the push, so we're pushing from our side of things, we're gonna push the physical therapy position as well from our end. So to try and get some more responses, and that actually starts next week. And then just other projects, new build team projects, working on signage for the hospital. So this is just general signage that's part of our packet, any donor recognition signage, anything like that. We are still in the middle of our partnership QIP survey stuff. So right now, the part that we're in for the survey is the educational piece with both staff and patients. And that is really just focused in on the clinic, because that's the part that partnership wants us to focus on for these surveys. And the target area is that making sure that partnership patients are educated on there are multiple ways to make an appointment, whether it's calling, coming in, emailing us. So that's that piece that we're working on. And then just some additional signage that's been requested for staff needs and things like that. And then starting in October, we have more meetings for the history wall in Union Hospital. So any questions?
So the employee Zoom signing event was very well attended.
Yeah.
And the three of you were doing your tours, I think you were doing, that was very special.
I think some couldn't make it. And we may need a little follow-up. The beam is still exposed. I think we need to be able to accommodate a little bit that in that regard. I do have a kind of a statement, and it's perplexing for me, and I've been struggling with this, and I know that Chelsea struggles with it, is that in the last couple of weeks, I have had no less than probably 7 encounters with our community that have said to me that I would probably go there, but you guys don't have any providers. And I'm perplexed by that.
Say, oh, you're building this new hospital, where are you gonna get the doctors?
Yeah, well, and my answer to them is, well, we're full. And we have
Yeah, I don't.
full-time physicians
Are you
taking,
talking about specialty care?
no, general practice. I'm perplexed by this because I want to say Chelsea does a really good job of getting out to whatever media we can get out. I really think that without a paper, like a Chester paper or like Elmore paper, people don't get on the website. People don't look at Facebook. They've given up on Facebook, a lot of people, which is, I get it, smart. But I did find out that the high school is the publishing crew. They are gonna be putting out a local paper. I don't know how professional it's gonna be, don't care what the distribution is gonna be. It's gonna be in collaboration with the chamber. So I gotta tell you, we have struggled for probably 2.5 years trying to figure out what's going to touch and get the communication out. But I was shocked how many people I have encountered in the last couple of weeks that basically said, well, you guys don't have any providers. And I'm like, we're completely full. They're taking patients now.
That doesn't surprise me at all. I have people all the
It's
time say they have a
mind-boggling.
hard time getting providers. They don't have providers over there.
Yeah.
I've
Well,
heard
they're
that
full.
many times, and I counter it.
Right.
I
think-
really don't know what to do.
I think it's a combination of, because there was a point where we did not have any providers accepting new patients.
You're right,
The problem with that is it takes
it's a lag.
it takes a time to overcome that messaging that then, because then people start telling that to their aunt, their uncle, their friend. And it takes so much time to overcome that messaging, because what has to happen is those people then once again have to learn. So it's that phone tree takes time, that word of mouth takes time. Now, we are, advertising wherever we can that we do have providers. What's interesting enough too is when you talk to some of those people, because I'll say, well, what do you mean by that? Some people will say, well, because I'll say, well, we have, Joe Russo, we have this, we have Stephanie, we have Lori, we have Heather. Some people still don't consider, Dr. Russo a permanent provider. Because even though he's been here for a while, he is still a locum provider in their eyes. And so unless we want to put out that messaging that he is here to stay, which I don't think, is the messaging we've decided to put out, because we don't know you're here. Some people don't want to establish that. There's also the people that comment to me, well, I need a doctor, because there are some, and it's a certain demographic and generation that really think they need someone with an MD or a DO versus a PA or a nurse practitioner. So that is one of the stigmas that we are trying to overcome, because usually once you get into the conversation with those people about that, then they kind of might change their tune a little bit, because I'll explain to them, we have nurse practitioners that not only do they have the education, but they've also have the hands-on experience. They've been in the hospital field, they've been in the private clinic field. So once you're able to have that conversation, I do think it helps people understand and consider, establishing with that. So there's a couple different things that we're dealing with. Also, it takes time, because you have that conversation with one person, then they go have it with 5 or 10 other people. But I do agree, it is hard to get that information out, especially to our main demographic here in Chester. But I think it's just time, and I think over time, we will overcome that messaging, as long as we can keep it consistent where we always have providers accepting patients, because positive messaging does not get spread like negative messaging. When we didn't have providers accepting new patients, that went around town like it was wildfire. It really did. And so that's where, people don't share the positive messaging as much. And as unfortunate as that is, that's what we are working to overcome. And that's why we have postcards, we've got rack cards, all of it with the primary care providers accepting new patients. And the hospital doctor thing, what it is people see that we're recruiting providers, and they don't distinguish the difference between we're recruiting for here, the clinic, and we're not recruiting right now actively for the hospital.
Yeah, I think that we talked about doing an expose to define nurse practitioners and physicians, and the fact that, I'll say it right here, nurse practitioners are gonna save the world, because we're just not putting out enough doctors.
Right.
Right?
Mhm.
And when you do 14 years of school, there's people just not committing to that. And if they do, a lot of them, they will specialists. They'll, might as well go another year and be a specialist. So we want to kind of do an expose to talk about the training necessary to become a nurse practitioner or PA, and what that means in primary care.
It might be time to do the round robin of visiting with the Elks and the Rotary and, all the
Might be.
groups again. We did it for the new hospital bill, but maybe it's an education piece, because then you're reaching more than one person to tell 5, you're reaching, 10 people to tell 5 each,
And maybe that's part of the outreach. I think it's a really good idea. I think that's part of the outreach, is when we talk about the hospital, that it's an easy segue to talk about our clinic and our primary care and the fact that we have we have providers taking patients. I think we
Every,
need to build that in.
at every community meeting you're at, I'd encourage you to just take it head on.
Say it.
I frequently hear people
Here's
say we don't have.
frequently asked question, we don't have providers. Let me dispel that rumor.
Yeah, just.
Yeah, when you say providers, you mean
Put it
doctors.
right
and-
out there.
What's the difference? You know me, I'll put it out there. I have no problem with that.
Yeah,
Okay,
we can do that. We can-
it's a constant struggle though to try to get that out
Yeah,
there.
on the paper, I was talking with Chelsea about that, yesterday. And it doesn't sound like it's gonna happen anytime soon,
No,
so it'd be nice if it did, but, I don't know. There's just having
we need
a
to
little bit
bring
of
back
trouble with
Chester
track at
Progressive,
high school. Who's on first?
Chester Progressive.
Well, and some people read that from the same,
Yes.
but it doesn't have the. It doesn't seem to have the distribution, and I think sometimes maybe it's because locally we're not making a big effort to put stuff in it.
Yeah.
So people don't see it as a good source of information. But it is a tool that's available that we could maybe use it a little bit.
We send everything.
Everything to
the
them.
Sun, and we actually do marketing with them as well. It is,
Their
yes,
choice what they.
it's their choice whether they put it in or
You
not.
might have to cultivate them.
Mhm. Yeah, so we have, and so the Almanac Foundation is actually one of their funders. So we actually, probably 6 months ago, I met with, Almanac Foundation and we did talk about the Plymouth Sun. And they are encouraging the Plymouth Sun to pick up more articles in this area.
I know they were looking
Yeah.
for reporters in this area. like
Right.
that.
I think what happens is they don't have a lot of reporters in this area.
Right,
So then even though they pick up our articles, it's not necessarily like they have a whole section on this area or things like that. Sometimes they get filtered down towards the bottom or whatever it is, but there's also just not a lot of people around this area that invest with in reading it. There's some, and I think part of it is, it's chicken and egg.
and I'm sorry, the digital format's great, but there's nothing like holding a
The
paper.
Intermountain News
Right,
is my
right.
mailbox.
There's nothing like.
Yeah, on a paper.
The Intermountain News is also starting to
miss
show
that
more
so
traction in here, so that is an option too, that we can push more marketing and more budget into. They're a printed newspaper and they are getting, cause he shares his numbers with me about once every 6 months. Their numbers have tripled up here this year compared to last year.
Plymouth?
No, Intermountain News, they're printed out of the Bernie area, yeah, and they
That's where
deliver
they
once a
want
week.
to.
Yes, and Susan.
So-
Williams is- Yes.
So it's a.
I actually publicly post our agenda
Mhm.
to,
Yeah.
that Intermountain.
Mhm.
Or maybe that's,
But I don't get a copy of it, so do you know if it actually shows our
Yes,
posting on there?
They will do our postings as long as it's in before their deadline.
Or maybe we turn our attention more to that and say, listen, distribution in the basin is gone. They're published, they're printed. So I think that there's a huge market here that was looking for a printed document. And then if you carry the news, I wonder if we should have a conversation with them about the readership here and maybe who would, I would
More
mention.
copies available in more locations in the area, when our stuff is in.
It's just holiday, they tried the coffee station last year and there just wasn't enough traction there. So for now, they're just doing holiday, but they do mail it to anybody that wants it mailed and it's nice, it comes
I can
right
tell
to
you
you.
right now, that a lot of the second homeowners that don't live here full time, when the Progressive was here, they got it delivered to their home. And it was huge for them.
I did.
Yeah,
Me
see,
too. Before me.
Yeah.
all right.
Just real quick, one of the other things, and I don't know how we would use it, but I know how effective it was. As supervisor, I had a email.
Yeah.
List, and I had a couple thousand people on that email list.
Yeah,
Matter of fact, I had broken it into 4 lists to
Right.
manage it. And that seemed to be something I heard a lot from people saying, I can't tell you how much I appreciate.
Direct email.
Yeah, direct email coming saying, this is what's going on.
Right.
Or you need to get over here and sign this thing before something horrible happens, or,
Right.
whatever the news is. And I don't know how we would develop something like that, but, it might be that we could take our patient base somehow or another.
With permission.
With their permission, oh yeah, everybody I had signed up. They
I
had to
have to
sign up.
look into, how we have, when we collect our emails, what verbiage we have on there. If we have the right verbiage, we could potentially utilize that to send them information relating to the district. That is something that we're looking into. We're looking into the formats for doing that, as far as Like being able to send an email and say, you know, right now is a great time to look into if you're 45 and older, a colonoscopy or whatever it is. Being able to send patients not only the health advice, but updates as we have a new provider, or we have all these providers accepting patients.
We check into the legality of automatically opting people in. Because if you do any business with anybody, you'll see it's the opt-in button is clicked for updates, information, and you have to click it to go opt out, because I don't want more spam, but, or more stuff. But
Yeah.
can we check about the legality of being able to use it? You're automatically opted in unless you say I wanted to be opted out. Anyway,
Yeah.
just thoughts.
I think it just really depends on when we collect the emails on our patient registration form. It depends on the verbiage we have right there in the email and
For sure.
on how specific we are on what we use that email for.
Yeah, okay.
So, but I will check with legal on that, and if that's possible, I can work with Candace on, seeing if we can extract those from basically it would be our patient portal. And we can get those, we can get something like that going. That could be a good way to reach patients that have already come here, or already established, but and then we can still work on people that are not patients yet, because
And
that's
those are
another
the
key
ones that are
area.
gonna have coffee with their neighbor who is not a patient.
Right.
And says, I would never go there, cause they don't have providers.
Right.
But then that person could say, well, I just got an email from them saying they got blah, blah,
Yes.
blah, you know,
Definitely.
so.
So
it's
is there-
not, well, it's not.
is there
I'm
a
not
way
saying
to
it's not
share-
work, cause it is work.
Right, Shelley. What was that, Shelley?
I was just thinking about, to Sean, your comment about the community saying we don't have any providers. What about sharing patient satisfaction? Or provider patient satisfaction results with
We have it-
the community?
Yeah, we have it on our website. We have our Google reviews and things like that. I haven't thought about distributing our patient satisfaction. I haven't thought about that, honestly. We do have available comments and satisfaction markers on our website, but not a lot of people are hitting our website either. You know, I mean,
Yeah,
we're here. There's no reason to hit the website.
yeah.
Have you got any thoughts to that?
Well, because I'm hearing like Stephanie White just putting her name out there. I'm hearing phenomenal things about Stephanie White. You know,
Right.
and a lot of people are sad. Dr. Ware is leaving, but I think I haven't heard personally a whole lot of comments about some of the other providers.
Yeah.
So maybe we should share that.
We do share testimonials on our website, so, patients do have to opt in for that. Just because it's, it's privacy, so we do share them on our website. We also do share them on our Google platform as well, and those are all people that have opted into that. But what we can look into is sending out some sort of like satisfaction reports. That, especially if we can do the email sign up or whatever it is. And we can start sharing some satisfaction comments. When we do the like LACC newsletter, and for all those local avenues that we do stuff in, we can start sharing comments about patient satisfaction and what provider it was about, to try and help push that as well.
I
Right.
did get a suggestion from someone that was here today from the country club about the newsletter and asking for, maybe we could provide them with some pieces on, educational, like how to drive a golf cart, or who not to let drive a golf cart, or the things that can happen if you tip over a golf cart, that kind of thing. So I know it's your favorite topic, right?
Like health related, or just general educational pieces?
Well, how to keep yourself healthy by not,
Falling off. the
Well,
golf cart.
yeah.
I can add.
There's some cute things that Judy will remember, because I think you implemented, like, if you step on a bee, go to the walk-in. If you step in hive, go to the ER. So
Yeah, that kind of
if
thing.
you
Yeah, it'd be
crash
fun.
your, golf cart, you go to the ER, so it just kind of top of mind of, maybe I should.
And then it reminds people we're here in addition to what we're already doing.
I can talk to that and see if we can start incorporating something in each edition that's kind of fun like that, and
I think she said they're switching that quarterly or bi-monthly or something because of.
they're doing they do every other month in the winter, yeah. And then hopefully in the
I'm
summer.
sure you know better than I, but the general public, they talk in terms of provider, or do they say, do you have a doctor?
They say doctor,
Yes. So let's recognize that.
right? So, they say doctor. They say, you know, you have no doctors.
Right.
And so that is something, that is where I said that is part of the, you know, the thing is, if, when I sit and talk to them, you know, Dr. Ware is retiring, she's not accepting patients, and then Dr. Russo, some people, they know he's here, but they're like, well, is he here to stay long term? Because they don't want to establish with somebody who is not here to stay. And so that is the biggest issue when people want, because there is, like we said, that generation that wants a doctor, but once you have the conversation and start talking to them about all the qualifications that our PAs have and our nurse practitioners have, it does help, and it does help alleviate some of those concerns, because it is a mindset that people sometimes have where they think they need a doctor to do all of these primary care things, because there are some people that have told me, well, a PA can't prescribe my prescriptions. And I'm like, well, they can, yeah. So that's just, it's a lack of knowledge on understanding of how it works and what a nurse practitioner or a PA can do and what a doctor can do.
I'm curious about, I remember a time when we knew every provider, I think everybody in the community knew every provider in town. So I'm curious about Sean perhaps taking out people on providers, in some of your meetings, introducing them, whole team.
Happy to do it. Happy to do it. It's getting them
Them
to
to show
commit
up.
to that and on their calendar. You know, they see.
Oh,
us
I get that, I
peripheral.
get that.
Peripheral.
If not a whole group, individually as you can, you know.
Yeah, I mean, I'm happy to have them join,
So
introduce them. We
we,
did that when they first started. We had a couple of things, but
we also tried a series of information stations where we tried to get the providers there. There were a couple providers that were willing to show up. There were ones that did not show up or were not willing to do that. And we do try and get the providers out to these things as much as we can. We invite them, it's getting them to come. That is really the key. So, yeah, that can be something we can maybe talk about in med staff and talk about the importance of getting them to come so that we can get the community comfortable with them. So. Again,
Still think there's nothing like a local newspaper.
Right.
Under Sean, that one.
Me too.
upset.
All right, anything else for Chelsea on marketing PR? Want to move on to your foundation report?
Okay, so I changed up the foundation report just a little bit. So the first part, the summary, kind of summarizes everything that's going on. So you only in the future have to go on if you want more details on those certain items. So that way it just makes it a little bit easier for you guys to read through and absorb. We did accept our first stock donation, which was a lot of work, but we are all set up to do that now. We do have a policy now, $2,500 or more for a stock donation, just because the amount of work it is to accept those. And the Collins family worked with us on that first stock donation, and they donated as a family unit, and so yeah, it was a good experience, and now we're all set up to do it. We've got different, staff engagement going on, trying to encourage, the staff to be involved with the new hospital and things that are going on there and encourage those deductions. So, the staff will receive information about, continually about here's how you can be involved, whether it's, volunteering, donating, whatever it is. And we're trying to keep staff updated with the monthly newsletter so that they know what's going on. We've got different displays going on and then lots of policies that we're working on. One of the things that have been requested is, the estate planning guide. So that's kind of a big one and we're working on that just to, help potential donors with their, estate planning. Then we did have the letter or year-end letter go out. That letter was from Sean this year. And we've already started receiving donations from that. And, that's about it. Any questions? Any questions on the foundation? Shelley, anything?
You know, the one thing we might stress in some of the marketing, especially if we get toward the end of the year. Because we all get inundated with please donate.
Right.
But as I mentioned to you the other day, I was not aware that I could take the required distribution from my IRA and directly have it donated to the foundation. And I think if we kind of made those types of things a little bit more public,
Yes.
because a lot of people are in the same boat I am, I prefer not to have to do it, but I'd rather have it go to the foundation.
Yeah.
And like I say, I'm pretty knowledgeable on most of those kind of things, but I just never realized that I could do it. And that the key to doing it was not giving it to myself and then giving it to you,
Right,
but having it transferred directly.
right.
So I think those are the things that really need to be looked at.
Yes, so we are working on that. So we're working on basically a handout for that. I did work with Jamie after talking to you.
Good.
And I sent her basically something that she can keep in her office that she can give to any of her, people she's working with that have an IRA or a QCD that they need to do that with. And so basically it's step-by-step instructions. And then we're also working with the Edward Jones and Susanville to do the same thing.
Good.
And so we've already started implementing that more and working with that. And we do have information on our website about that, but we are also preparing like an article series to go out with information on all of it, because there are a lot of people that they're not sure what all they can and can't do with it. The hard thing is, what we find is each time we accept a donation from an IRA or a QCD, it's different depending on the financial institution that it's held with. And so as we work through these different companies, we're kind of developing the guidelines and process for all of
On
that.
how to work with them.
On how to do it. And I mean, they're very similar, but some have different requirements and some have it just is a little bit different depending on who the financial institution is. And so, yeah, thank you. Any other questions for Chelsea? All right, thank you. So I think that brings us to item number 7, Chief Financial Officer reports, and we have handouts here provided to us. Go ahead,
Do
Steve.
you wanna start with August or just wherever I wanna mix it in?
Wherever you want.
Okay, Ethan, can we pull up that document I sent you earlier? Ever sent it to you as well? Pretty much the meeting today so far has covered everything I was gonna speak about. So. Spare you guys. So again, this was a month where lots of things happened for me, personally and professionally. So I was unable to get the full report for the month of August to you all. Nor was I able to get this out to you guys in advance. We did review this information at Tuesday's treasurer's meeting. And Deborah sent this out to everyone else, or the remainder of the board, I should say, today. Did it go to Shelley as well?
Yeah.
Oh, fabulous. Okay. So, what I wanted to do is just buzz through the month of August and it's really interesting because having that strategic meeting that Rich and Shelley and the admin team and Linda McCurdy were at earlier was really perfect timing, because the financials for August really speak to the conversations we had there. Where Brady did his strategic plan and had all these quadrants of things that we're gonna look to do, and one was revenue growth. And one of the things I mentioned from whatever my brain is of being an accountant, versus a free thinker or whatever, is that I said, how can we have a strategic plan when we have issues facing us today? You know, and how do we address these issues
into our strategic plan. And one of the issues that we faced in August was that our revenue, overall revenue fell in relationship both to budget that we had and also what we saw in August of 2024. And so we had a conversation about that in general and the fact that it was in multiple areas. One of them was in the primary care area, our clinic visits. As yes, you can see at the very bottom, we're down. And so we just had a long conversation because it was, as you can see, that the negative variance really was in our outpatient revenue, right at the top there. And inpatient, we're not budgeting very aggressively for, as we've talked about previously. And we do have some ideas there, certainly some strategic or real plans for addressing that. But it was in the outpatient area, which really concerns me because that means the people that are utilizing our hospital somewhat by choice. Obviously, they're here because they have a medical issue that they're seeking help with. But this is where we can really control, I guess, utilization and revenue is that the public, and that's where I'm half kidding, half serious, is that we really had a long conversation about our relationship with our community and getting people to utilize both the current facility and the new facility. So we talked about that quite a bit, and I think that one of the quadrants that Brady had in his strategic plan was rural health clinic or primary care stability. And that's from various perspectives, having the providers here, and then now we face that lovely additional challenge of they're here, but are they staying? So so these are all the things that affected us. Fortunately, we've seen somewhat of a recovery into September. It's more in line with, it's gonna be more in line with budget, and it's gonna be more in line with September of 2024. But one of the conversations that we had in the treasurer's meeting was that everyone seems to get a sense that, boy, this town cleared out fast this year. And so, again, we talk about this from two perspectives. One, yes, we lose that additional population, and then, you know, there's nothing you do about that, as we've seen the revenue go from July to August to September. But where we really have our, I don't know if it's a gap is the right word, but where we really have our challenge is when we go into the winter months and we're serving our year-round residents. And I always say this, you're gonna say, I'm tired of hearing it, but I come from an area where summer was our slow time and winter was our big time. It was our big revenue time where we had flu and all the other seasonal illnesses. And so that's something we're also looking to in the comment about addressing geriatric care is a big one, because when we had our market study that we used for the financing on the new hospital and the feasibility was that they said that our population is aging and that geriatric care is it's one of the areas that we could have higher demand and we could have a real use for that. So that those are the things that we're looking at. But when we roll out the August financial statements, we will see a negative variance to budget, both in the revenue and certainly in our bottom line income. I put in the stats in there and they're all pretty straightforward. Long-term care was down in August. Our census was 13.9 days, average daily census of 13.9 residents, 16 beds. As Judy mentioned, we had our call, our monthly call, internal long-term care meeting call, and right now we're up to 15 and we're looking to fill the final bed. One of the things that Seneca has done when I first came here and for quite a few of the years that thereafter, we only have female residents, and taking male residents was a new thing that we did. And so we have male beds, we have female beds. And so right now we're trying to fill that last male bed. And like I said, I don't have worries about long-term care. We do a very, very good job of getting pay sources, which is almost entirely partnership or Medi-Cal. And and we're paid extremely well for long-term care, knock on wood. And so that's one we just don't worry about it. It always comes back to we run a great nursing home. We're all excited to think about what kind of nursing home we can run when we have a brand new facility that's laid out as so dynamically as it is. So that's kind of what we got here. I don't know if, you guys haven't had much chance to look here, and I think it's just, like I said, I hope that what we're seeing August was really just kind of an outlier or aberration or whatever, because September did come back, not robustly. And it's something that we're gonna have to do, because right now we're not budgeting very aggressively by profitability, or at least for fiscal 25-26. And when we get into 26-27, we're gonna have to build that up, because as we head into the new facility, we're gonna have to have that higher level of profitability to meet our debt service. And so, lots for us to do, but at least we're talking about it. And as I mentioned to Rich said, he says, well, what options do we have, and who can help us, or whatever, and can we get this money? And I said, to some extent, we're on our own, but the good news is that there's incredible opportunity here. We have unserved market right now, and we have an underutilized facility in multiple areas, mainly from the inpatient side, the swing bed program. We still have capacity within the clinic. As Brady said, we bring Dr. Greg on board, then we'll be back to our 5 doctors, mid-levels, nurse practitioners, whatever. We have 5 providers, and we can see a lot of people with that.
When I hear you talk, I think we need 2 things, a newspaper and a ski resort. Get some wintertime activity in here.
Extended run.
Right?
And I think dog sled races on the new,
Yeah.
That there.
on the new, like that. All kinds of ideas. I'm sorry, Steve.
Not at all.
That's not gonna help us at all.
More interesting than, I was just gonna say that also I drive home, I live in Cedar Lane in Hamilton Branch, and I stare right at Bear Mountain every time I drive home. I said, I see the vertical there, but it's just, the base of that darn hill is too low. There's no way that the snow will stay on that, but
That's the other side. It's supposed to be.
the top of it's gotta be great.
Yeah.
Absolutely. So, okay. Just from an operational standpoint, now we'll talk a little bit more in the R1, the revenue cycle section. We've kind of had some bumps and bruises in this fiscal year so far, July, August, and September. In July, we had our little issue with trying to bring in R1 to support all of our coding, not just the clinic, while our coder was away from the facility. It wasn't as successful as we had hoped it would be, and we learned a lot from it. And then when we went into August, we had an issue with our long-term care billing. This is something that we're really experiencing. I've never really experienced it before. Is that when something breaks in our system, whether it's in Cerner, whether it's in Americare, which is our long-term care solution, or what we're experiencing now with the radiology, it just affects so many areas, and as far as the financial side. And in the case of, we've had 3 major incidents. We lost the connection between Cerner and our billing clearinghouse, and they weren't talking. Therefore, we could not submit any claims to our billing clearinghouse for 10 days. And it's like, we're going back and forth, and it was, I've never seen challenges like that. Then with Americare, the same thing happened. Somebody changed an IP address or whatever it was, and we were not able to get our claims to go from AmeriCare to, again, to the clearinghouse. And, you know, we're dealing with different things. It's not like everything's in one location. Under Evident, we had everything in one spot, and that's good and whatever. I mean, the system was a Volkswagen, as a very to, you know, the high performance, but the high performance breaks, and when it breaks, we have to get multiple groups talking to each other, and first we gotta get whose issue it is. That's what Ethan does. Ethan brings them all together and gets them to say, okay, it's my issue. We just see a lack of them saying, how can we help you? It's like we have to prove to them how they can help us.
Yeah.
And it's frustrating, but we eventually get there. Same thing with radiology. We're just about there now where we've got the images and everything moving, and now the MedWeb and Synthesis, they're saying, we're sending it to Cerner, where is it? And so that's where we're at. But we just keep having these bursts, and I'll talk a little bit about more in revenue cycle about how it's affecting our numbers, but it just seems like you know, we're looking for that perfect month. We're looking for that perfect run or something like that, and we're close. And I really appreciate the way that Ethan works with finance so closely, and his team, his whole team. So anyway, so we're seeing some ups and downs in AR a little bit, and then we're seeing a little bit of hold up on the cash flow. Well, pursuant to what going back to the coding thing, what we decided was every month we're going to send we're going to have R1 do all the coding for 2 days each month, so that they can keep their team up to speed, and they've dedicated a second person. So if the first person's not there, the second person just comes right in. And so Shell Stoops happen to be off the end of the month here, today, tomorrow, and Monday. And so we're gonna have R1 do the coding, see if we have any better results with that. So that's that.
Are they gonna do those 2 days together, or are they gonna split out? Or just,
They're just gonna each day, everything that hits the coding bucket, they'll do. So whatever goes across.
but you said 2 days a month, right? You don't mean?
Yes.
In good practice?
Yes, they'll do them together. I'm sorry.
Okay, so I was wondering if that way they can kind of
Oh, yeah.
follow up the next day if they miss.
Yep.
Yeah, okay.
This isn't an action item. This wasn't on the agenda at all, so I guess we'll just move on unless there's any further questions.
Any other questions on this one? Go ahead, Susan.
See, what you didn't mention in there was what was mentioned, well, no, that was mentioned previously, is we had traffic here for August, right? Traffic problems, road delays and everything.
Yeah, I wish I could
But we can't quantify
Can't
that.
wish I could get a sense. I know it's beating the heck out of our employees that come from Susanville, so, you know,
And West Shore and everywhere else. Sure.
yeah, I don't know. August was,
I suspect that's maybe a bigger impact than we realize, because I've avoided traveling east at all costs.
I know it's been impacting businesses in town.
Yeah.
Yeah.
And I think you're right, that's why town cleared out as fast as it did. It's
Yeah.
just too big a hassle getting stuff done here, so they went home,
Now we have 89 as well.
right?
One of these years, maybe we won't have road construction. All right, so are we going on to the
Yeah,
cash flow?
cash
or-
flow.
Okay.
back to the Civics, Ethan.
I'm sorry, the phone call started right when you said that.
Citizens.
Right in my ear.
Okay, there we go. Perfect. Yeah, I just wanna point out a couple things just real quick. And I'm fortunate I caught something after sending this out to you. You go down from co-pilot in the September column, down under the reductions to cash flow or to cash, there's $383,537. That was the, you all had given us direction to go ahead and pay some of the, what we call soft costs, which is everything but, the general contractor and equipment. For the project, because the USDA is holding up payment on those soft costs until we get 100% of our contracts reviewed and approved by them. We're pretty darn close, and then, of course, this government shutdown thing could impact that. But thankfully, they approved OR 13, which is the July request for Molly Hamlin, and that's probably the most important thing. Keeping those guys behind us, working and happy. And so we will get that money back. So I just, in my new cash flow, I'm really hoping it's no later in December. I think it's government shutdown, notwithstanding or dependent, is that we should have, they're getting close to reviewing everything. So if they can keep working, we should, by the end of October, have all the stuff reviewed and we can put in the request right away. And I don't think they'll mess around with it. They'll just make sure all the backup is there. And there's really nothing complicated about the way we request items for soft costs. They're just invoices from various vendors, as opposed to trying to do the juggling between contractors and subcontractors and all of that we have on the construction contract. So we'll get that money back. The other thing is we're coming up on our big IGT for rate range in November. I have initiated the process of the line of credit with Western Alliance Bank. They've requested some financial information from us. I've sent that to them. And so my anticipation is that we can have a line of credit to you guys for the October board meeting to for your review and approval. And then that'll cover us. We'll do the IGT. It's in late November, so we have a little bit of time if something happens. And then we'll use that line of credit if we get in a pinch there in December. And in January, we should receive our supplemental payment on the rate range. We're 100%, no, we're not 100% partnership, that's not true. Kaiser's gonna give us $400,000, but the bulk of that $7 million is partnership, and partnership is very good about paying. As of today, they like us, so you should have no problems with that.
And to your point earlier, December, our number for cash days on hand should tick up a little once we get that 383,000 back.
Yeah, I think we're running 60,000, so it's gonna be another 6 days or so.
Okay.
6-7 days.
Thank you.
Yeah. And that's all we have there.
Any questions on cash flow? Okay, moving right on, we know we have the O1.
Yeah. Just want to go through a few things. Right. Yeah, so yeah, right. So. But we had our weekly leadership team meeting, if you will, on revenue cycle, which is myself and Sarah Lynn, the revenue cycle coordinator, and Erica Baca from R1, and she presented September's. And I'm just gonna go through here. And going down our numbers, you can see there's a lot of green arrows. I don't know why that arrow is up on the, oh, it's up, up is bad. We're still working with that. Green is good, up or down, red is bad, down or up. So
The colors.
we tried to make it not confusing, and I messed it all up. So, but the big thing here is that when you kind of dive into this, if you look at the areas where our numbers are bad, they're outside the range, or they're trending negatively, it's not about us. It's not about Seneca. It's not about R1. You know, our total AR is, I think 76.6 is our, I think our best number ever since we've gone live with Cerner. As you can see, it's still not an acceptable number, but it's all in our, self-pay, non-third party error, because we still cannot transfer accounts to bad debt. Again, we're not gonna get a lot of money out of that, it's just gonna make our numbers good. So what I always like to focus on is I like to focus on that second line down in that AR and aging section. Total insurance should really say third party. So everything that's third party, our AR days now are 47.9 in August versus a target of 45. So, I mean, third party is where we get our money, is where we get our payments. So we're darn near 45, and 45 is within the best practice range. So that says a lot of good things are happening. So again, the AR greater than 90 days is above the target 42 versus 30. It's all within the self-pay. We look at our third party AR days greater than 90 days, it's 19 versus 25. So those are really wonderful numbers. When I move down into the credit balance isn't horrible. It's 2.7 versus 1, but as soon as we can get that, refund process working through Cerner, then we can start doing active refunds. It's not like we're sitting on that money because we don't have the money to pay it. We will. And we absolutely make a refund when it's requested by a patient or a third party. The insurance companies usually just do take back, so we don't have to worry about it. The denial rate obviously spiked in the month of August, and this is another one where I'm saying Seneca's good, everyone else is bad. You know, Seneca and R1, the CMS has identified an area of potential incorrect billing where the professional fees, so say in our ER department, our ER physicians, they assign their benefits to Seneca. So we just pay them for their time, and then they sign off and say, Medicare, go ahead and pay Seneca our professional fee, part of the emergency room service. So what Medicare believes is happening, I guess it's because they think their system can't catch it. Usually it should catch a duplicate claim or a duplicate payment, but they think that there's situations where they're getting the facilities getting the pro fee, and then the physicians turning around and billing for the pro fee as well. So
Not us specifically, just in general.
everybody got pulled into this one. And instead of going in and looking into where there was a valid assignment of benefits, where we do this in it's called the PAYCO system for Medicare, they just denied every single claim that had, or every single pro fee that went in, and until they sorted it out, instead of going in and looking, is there a valid assignment of benefits? And so what happened is all those claims got denied. That's what drove up our 15.7%. And then now we've been able to resubmit those claims. Today, R1 said that 95% of those claims have been reprocessed, which means Medicare accepted them. They don't have an exact number on the payments yet, how many of them paid and fully adjudicated, nor have they identified any of our payers that are getting currently rejected for not having the assignment of benefits. Something we've asked Joanne Malik to look at. It may be something that's going to have to get handed to the new individual to help us with when they come on board. We're not sure of the timing yet.
Do you know how long it'll take to get this number adjusted then?
Yeah, it's already gone down. The September number was 9%. So
Okay.
How long it's going to take to get all the claims settled? We should be good if they're saying that 95% have been processed. You know, the majority of them are going to go through, because that's a standard thing we do with our providers. We immediately get the assignment of benefits. It's not just ER, it's Dr. Jensen in the surgery, Dr. Watson in surgery. It's all outpatient services, so that was the big one there. Now, what's really interesting is this client assist here. What it is, it's the number, it's when R1 has an account that needs something to be done. Some of it is with R1 and some of it's with us, and you can see how that number has been 8, 6.9, 8, 9.1. The September number is 5.6, which means that now we're starting to resolve stuff too. So these numbers are all moving in great direction. It's just these final pieces that we need to get finished. As I reported at previous meeting, we have started meetings with our client success manager with Cerner Oracle. And we've held 2 meetings with them. We've worked up an inventory of things that we need from them, and we're about to submit that to them. It's a combination of current issues we're dealing with, mainly from how they're managing our inquiries or our service requests, SRs, but it's also to identify the areas of our build that are incomplete that we're asking them for specific assistance with that. One of the big things we've seen already from working with them is that there's a email where when we submit a service request, it goes to a individual Oracle Cerner Oracle staff member, but it also, there's a mail thing where all the SRs go to, and somebody sits there and reviews it. And this is what this guy, our new success guy, is doing. And so I guess we're seeing some movement on things and we're seeing some success. We're still having some of the same struggles, but we can see that someone from that email address, COMI, whatever, is making comments, say, do this, do that, whatever. And just recently with this, one of the unique things of being in California and being a rural health clinic is that we have to do these wrap payment billings, and we put we get paid by a primary payer, and then we submit a claim, a secondary claim, and it could be for other things. You have to put a penny on there so the claim will generate, and we're struggling with a penny versus zero. And took us a year to get penny versus zero to work, but we finally got it into production now. And so, but it took us a year. It took us a year to resolve that. So, I don't know if it's just the timing of it, but it got resolved under this new watch. So we're starting to see some movement, but anyway, so hopefully that we're gonna get some of these pieces that are not functioning as well as we are internally, we in Seneca and R1, to be resolved, and we can see some really strong numbers. I mean, everyone's really pleased, because again, there's just been an immense amount of work. We talked about going into the work for the new hospital. It's just like, you know, we've been doing a lot of work around here for the last couple of years. And
Is the target to be determined contingent upon some of the stuff you're talking about right now?
yeah, because I think it's client assist is, I don't know that there's an industry standard for that, you know, it's more reflective of the environment. You know, how many things are we doing that are creating issues, or how many things that we have to specifically deal with, which is the definition of client assist, that they're gonna set that. But I think 5 is kind of like our discharge, not final bill, best practice target. So I think that's probably gonna be a fair number. And
I was just curious about it.
And the fact that we will acknowledge we weren't doing, you know, we were not actively working those, because as I think we've talked about before, we've gone from a build, fix, build to now revenue cycle management. And this is what this shows. So it's kind of like, I tell the R1 people when she has a slide, can you go to the next slide, Ethan? Let me see if it's there. Yeah, so she'll pull up this discharge not final build, and we're at a you know, $999, and we have these incidents of things that are happening at that time and whatever it may be. And I'd say, just don't even bother talking about it. We know what's going on, and it's, you know, it's like torturing yourself to to talk about it, and so. You know, same thing with client assist, when we knew we weren't doing it, why put a target that we're never gonna hit? Wish they'd do it with self-pay, but we have to see that self-pay target, because that says we're not getting the bill done. So that's one thing we need to keep, but
At least you can watch the trending on the ones where there's not a target set yet.
that's absolutely true, and that's why we tried to put the arrow in. To highlight the trend, so. I think that's all I wanted to cover with R1. I don't know if there's any questions or comments or.
Questions on the R1 report, Shelley?
Oh, yeah, Shelley, sorry, gosh.
No, I think, Steve, I can tell there's been a lot of work going on. Around the AR. I mean, there's still room for improvement, but it looks better.
Yep, thank you.
Thank you.
We agree.
So then that moves us to the interim financing and project payment update. Is there anything you want to highlight?
Not really. This is just a slam dunker. The only thing is that we made, I should have to look and see if I put it in there. Wait. Shoot. Okay, we made, after this was published, prepared, we made the, September 25 semi-annual interest payment, both on the GO note and the certificate of participation, so. Everything's current with that.
Thank you, Steve.
Yeah.
Any other questions for Steve? All right,
you.
thank you.
Good work.
All right, that brings us on to item number 8, new critical access hospital skilled nursing facility, requesting approval for the medical equipment overall list for management to a maximum budget of $5,453,169 with no contingency necessary.
No, goodness.
She added that just for you.
I thank you, Don.
All right, Donna, are you on?
I am.
Are you gonna take this or?
Yeah. And then Brady, Sean, Judy chime in if and Linda if chime in if there's anything I'm missing here. But this is we've been bringing to the board this intent in previous months that we have been working the hospital and the medical equipment planner have been working diligently to bring this equipment list to a point where an associated budget can be pinned down, and we have gotten to that point, and what we have here is a list of equipment that we want to be able to procure to, with having some ability to do the negotiations with the vendors, make some tweaks with the procurement level specifications, and ultimately land with the total budget as is indicated in the meeting agenda. So all this equipment plus, let me make sure it's clear that this equipment plus $200,000 for instruments is what adds to the number that we're asking for the board to approve. It is all that total number is what we have in the budget without using any contingencies, any project contingencies. And so we're asking for the board to approve that dollar amount to be able to procure within these parameters.
I liked how it was broken out by room, but I thought it was kind of funny that the room number started at 200. I'm like, we only have 1 floor.
Department 200. Any questions?
Well, I want to know if anybody has questions. So this is the exact specific items that we're gonna get, and we have specific pricing on all of these items that gives us to this final number.
We
Is that right?
do. That's
Yeah.
correct. And there's, these are, there will be through the procurement of this list, there will be, like, as referenced, there'll be some additional detail that will come from this, like, for example, the gurneys, we're still, figuring out the absolute specifics of every, bell and whistle, so to speak, that needs to be a part of that. But but all that will be worked out in procurement through the quoting. And what we're asking is the ability to manage to that bottom line and make sure that we can have some agility with issuing the purchase orders within the parameters of that total and this equipment.
So I would imagine the purchase orders will be issued in stages too, right?
It'll all be based on lead times. So I'm working with the team to put together a schedule, a scheduling effort that allows all the owner furnished items such as these to determine where they fit within the schedule, the construction schedule, and then work backwards with the lead times. And so the procurement of these items will be determined, the cutting of those purchase orders will be determined based on all of that effort. So
That's something that transition consultant will help with also, right?
Correct. Yeah, so in this, Linda, Judy, team went through it, so we have a baseline of each room, each everything. And then from there, when we get to the timeline, like the booms, where that's part structure too, that's why that came soon, because of where Jimmy is on that. There are other items that are, in Inc. 3 or Inc. 2 in this list that will align with the timeline that Donna's talking about. Now, with that, there's still the ability for us to negotiate with those companies on certain things that, Judy and Linda have identified. Some of these, like that bed there, is a Hill-Rom. Well, as we're looking at some other vendors out there that we've looked at, we might be able to do a package deal, which then works in our favor to that number. So, but this gives us the kind of the gunpowder.
Baseline.
Yeah, to go out and start arm wrestling, but also keeping an eye on that timeline when we actually have to get them in. And not only structural wise, there's a whole staffing component from training wise. So Judy has brought up crash carts. If at all possible, we could get those prior to that, so that we could train the staff on that. That may be something that we want to pull through early, but this kind of gives us that to start working on, because this is, timeline short, it's here, so.
It also takes into consideration supply chain, time from the vendor. How far out are they for delivery? We've got that's a component of it. Some of them are way out there.
Where are we gonna stage it? As we start getting things in before.
A lot of times we don't have to take delivery. We will buy it, they'll
hold it until.
They'll hold it
A lot of
until
it,
in
much of it.
all training, stuff
Good,
like
that's
that.
they have
Gurneys, that's all in the negotiation of like the deposit, there's all that kind of stuff that we'll kind of negotiate with.
Another question about it, I can't remember what I was looking at. Sure.
I'm just curious, once all this is purchased, installed, everything looks good for you, is there some training days set aside?
Oh, yeah.
Yeah.
Dan, there's
a lot.
not only do the vendors come out and train, let's say on the new radiology x-ray unit, we have to go through all that. But then the nursing staff on, the new monitors and all that, that's the whole day in the life, the training that that last 6 months or 8 months, we gotta get in there, we gotta get everybody trained.
And you said 8 months?
Yeah, probably about 8 months, because when it comes to, I mean, the basics of the floor and floor care, that floor is different than that floor. And we're very thankful of that. But there's that floor care, so we need to have the vendors, the material, all that stuff. So this next year is gonna get really busy, because you have to know how to, once you receive this hospital from the construction, it's us, and we have to know from top to bottom how that thing functions.
And this is likely where you're likely to incur
Extra
overtime
costs.
costs.
Yeah.
And a lot of times the vendors, for the first, say, week of operation will provide somebody there to make sure you're not pushing the wrong buttons, that they're there.
Yeah.
They're in servicing you there actively, and they just kind of teach you one, show me one, then, okay, we're good, we're fine. You know, so there's just a lot to that. You know, Judy brought up a very good point. You talk about training, you know, how do you approach a helicopter?
Yeah.
The whole helipad, how to properly approach, what to watch for. We gotta get training from all of like.
Or when one comes in,
What?
do we block off some of the access points because of, you know, family members? I mean, there's all of that
Kinds of stuff to
that
consider.
we have to think about.
Fascinating.
It is.
You have a question, Steve?
Hey, so Donna?
Yeah.
Sorry for not getting this to you sooner. What is the relationship between the number that we're putting forth to the board versus what's on the USDA budget report?
It's exactly the same. It's, because let me pull that open. We have, because also within that equipment is signage and furniture. So the reason I imagine, Steve, that you're looking at the SF 271 right now, but the line G of that includes other dollars for things beyond the medical equipment. So line G, this number that we're asking for is the same component of that line G as was originally planned. Like it's one and the same.
Okay.
That does bring up my question, which was whether we need to do this using the language with USDA concurrence.
Well, so USDA has told us that they don't want to review these. So I don't think, they've told us that all that they want for medical equipment is to see it as it's being billed. As we're getting the invoices for them. So
And
as an
the
example.
Is gonna be this will be our
What's that?
backup form?
Yeah.
I'm just wondering
Yes.
what their paper trail.
Yeah, we'll have the backup, we'll have their quotes, the invoices, all of that, you know, so that when one gets put in, you know, whatever.
Yeah, if I can give the example, we have one invoice being processed with this next outlay request for the striker purchase order that was approved by the board previously. And so what's going to USD, so that didn't go to USDA previously, because they said they didn't need to see the individual purchase orders. Instead, what's going to them now within the outlay request is a summary page that shows the overall purchase order value with the terms that were agreed upon on that purchase order, and then a tracking of the dollars that are being billed as they're being billed. So like this first payment it shows the summary of the total purchase order. It shows what the invoice is and what the remaining balance is for that purchase order. And then behind that is the invoice and the associated purchase order. So
And the summary will let them know this percentage, and then when it's reconciled at the very end, it'll be a summary
Right.
saying this is the reconciliation of the purchase.
Great, thank you. All right, any other questions on this? I can tell this was a huge amount of work, so thank you to Judy and all the team that went through.
Lots of
the
review.
diligence.
Lots of
Yeah,
review,
yeah.
Trash can, yeah.
I don't know about that.
I was looking at it, I'm like, yeah, I don't think I wanna have to throw a return by the trash can, so. Do I have a motion to approve this request for the medical equipment? Thank you, do I have a second?
I'll second.
Thank you, all in favor, Rich?
Aye.
Sherry? Ken?
Aye.
And I'll vote aye. Thank you, Donna. I think that brings us then to item number 9. New Critical Access Hospital Skilled Nursing Facility, request approval of add to building RX contract to adjust duration of services to align with current construction and closeout schedule. No contingency needed.
Yippee.
So Donna, do you wanna kind of give the highlight of the purpose for this and? mention-
Sure, Sure, so previously, the Building RX contract previously had first patient going to starting 9/24/25 as you see on the screen here. What we know now is that first, I'm sorry, I'm trying to. So it's actually the impacted schedule is what we need to look at. So previously, first patient was 1/20/26, and then it went to 5/28/27. That are the dates that you're seeing there. And so the service amendment 2 is to get that to have building RX coverage for owner's rep construction management services for those additional months. We had submitted this way back when, and it didn't end up coming to the board because we were getting initial pushback from USDA, and now that they have a better understanding of what everyone's doing and the schedule that was agreed to before and the schedule that we're at now, they've indicated that they understand where we're coming from with this. So that therefore we're bringing it to the board so that we can then get it to USDA officially to have the Building RX contract amended.
And we had included this total dollar amount already in when we did the updated bid. for our
That's correct.
Current contractor, so that's why there's no contingency needed, in case that wasn't there.
When we got the letter of conditions, the second amendment to the USDA letter of conditions, we knew that the schedule was being extended. That's why we had, there were dollars that we had for HGA for the same reason. We had dollars in here for Building RX because of the same reason, of the extension of the schedule. And so that, like you said, there's no contingency being used. It's just getting the contract updated to use the dollars that were allocated for this purpose.
And then hopefully, once this is done, then we can get your contract. Through USDA, yeah.
Correct.
So do we have any questions on this? Comment? Motion to approve? Thank you, do I have a second?
Second.
Thank you, all in favor, Sherry? Aye. Ken?
Right.
Rich?
Aye.
And I will vote aye.
Thank you, board.
Thank you.
Donna, are you gonna send this to me electronically?
I am, but I'm gonna do it once I get the contract, the overall contract approved by USDA, and then I'll send
DocuSign.
yeah, you got it.
Perfect. Thank you. That brings us into item number 10, new critical access hospital skilled nursing facility general update. Is there anything we haven't talked about already?
I feel like really there's not a lot new here other than the two things that we just talked about. The definitely the medical equipment is the main thing that was updated on this report. Other than that schedule, we're still in discussions about. Budget is tracking. We don't have any, as you know, we don't have any contingency usage requests this month. And you're aware that the soft costs are being held. So we're working through all those contracts and the associated change orders that are associated with those previous soft cost contingency usage requests. And no, nothing to report on permits. I believe the executive team gave a good summary of where we stand with the construction. And as far as the outlay requests, as Steve indicated, we just got so we've had outlay requests 12 and 13 now approved. 13 was just today, so we'll be sending that into Western Alliance for payment as soon as possible, and should be able to submit outlay request 13 for work in August here. It was just sent for our signature, so we should be able to get that in tomorrow.
That'd be 14, correct?
Yes, correct.
Sounds great, Donna. Any other questions for Donna?
Nope.
All right, thank you.
Okay.
Thanks, Donna.
Thank you.
Okay, moving on, item number 11, policies and procedures. Anyone have any questions, comments on policies? Move to approve. Move to approve. Do I have a second?
Second.
Thank you. All in favor? Rich?
Aye.
Ken?
Aye.
Sherry? Aye. I will vote aye. So now we come to the medical staff report. See, we have several initial appointments and reappointments. Do I have a motion to approve as approved by the medical staff?
I make a motion to approve.
Thank you. Thank you. All in favor? Ken?
Aye.
Barry? Aye. Rich?
Aye.
And I will vote aye. So that brings us to the executive session.
Smack. Thank you for bringing me back in. I'm use the restroom.
Okay, we're back on.
Thank you. All right, we just met in closed session pursuant to government code 51956.9 legal counsel, and there were no reportable actions taken during our closed session. Future board meeting agenda topics, board planning session, actually getting a little closer on that one, thinking perhaps somewhere around February, March. Once the subgroup for the strategic planning kind of gets things rolling a little more, we have to convene as a full board to do this, so that's my thought. Any other topics anyone wants to see added? No?
Yep.
Okay, well then with that, our next regular board meeting will be Thursday, October 30th, 2 p.m. here in the conference room, and our meeting is adjourned.
Thank you.
Thanks for joining, Shelley.
Well, I think figure out if that little dog comes back. How more it gets, yeah. I mean, it doesn't know me, and apparently the people that raised it didn't give it a name because they